for it.
You see my screen?
Yep.
All right, welcome everybody to Vice. April is going to be all things knee, and so I appreciate everybody giving feedback. Sorry, go ahead. Try to mute if you
I'm
can.
just going to mute everybody. That's green light. Okay.
That's cool, and then just I can see the chat box. So again, like if you have questions as we're going, comments, feel free to use the chat box. I will definitely address your questions and comments as we go. Thank you for the response on the poll. That feedback's really helpful. Honestly, I think I was going to take this in a completely different direction. The overwhelming majority of people, though, voted for soft tissue injuries and tendinopathies, and then degenerative knee conditions, kind of the aging knee, and what we see in these degenerative meniscus cases, and degenerative joint disease was another kind of popular one. So we will get into that. And our second half tonight's going to be big time soft tissue injuries around the knee, particularly tendinopathies. And I'll really focus on that, and then I'll get your feedback on what we want to kind of further include in the next session. So here we go. We'll do patella tendinopathy first, which is, you know, the most prevalent of the knee tendinopathies. We're going to cover all of them. If you had never personally experienced a tendinopathy, I think that this can be perceived as a relatively benign injury, or an injury that maybe isn't that severe, doesn't really sideline people. But when we look at the literature, a lot of people are sidelined due to tendinopathy. And so everything, you know, recreational athletes, competitive athletes, and then you can look in your working population, your people that have physically demanding occupations, you know, all of those patients can potentially be sidelined from tendinopathy. When we look at the patella tendinopathy, with the two images you see there, so the MRI on your left is probably the worst case of patella tendinopathy you would ever see on an MRI. The whole entire thing is swollen like that. It's 3 times the size of a normal patella tendon. That's not what you will see most of the time, right? That's probably due to blunt force trauma or some type of traumatic injury. Most of the time you're going to see this just localized fluid accumulation and breakdown in the proximal aspect of that patella tendon, just inferior to the patella, right, on the inferior pole of the patella, and on that kind of retro surface of the patella right there. That is hallmark patella tendinopathy. Think of it as a process, not a single condition, right? So don't worry about whether it's an itis, it's a partially torn. I mean, this is a longitudinal process, and what we do is we pretty much see breakdown over time, right? These patients will go through periods of exacerbation and remission, and it can be inflammatory at times, and it can be very swollen at times. It can also sort of create a broken down kind of haphazard matrix of collagen as well if it's allowed to persist. So early on, you'll see swelling in that tissue, and you're going to treat that, right, with kind of your typical offloading, swelling reduction type of techniques. And then what will happen is the body will respond by really trying to heal and stimulate healing, so you get more tenocyte activity, fibroblast laydown, and all of a sudden now you've got this kind of tendon matrix that's sort of haphazard in nature and really unhealthy, and that's kind of the second image that you see there.
Yeah, that was surprising. I mean, not too surprising though. I mean, I actually, you know, I knew we were going to get at least one more snow. You know, it's just you're not really out of the woods until June.
There you go.
Oh, that's so
And then more breakdown, right? So as that is allowed to persist, you're going to eventually end up having fat cells and scar tissue inside there. When we see spontaneous tendon ruptures, a lot of times we think that's really, that was, you know, predicated by a swollen, broken down tendon to begin with, right? So the tendon weakens over time if it's not addressed properly. So think of it as a continuum and as a progressive continuum when you look at the pathology. The actual diagnosis itself, so when we look at patella tendinopathy diagnosis, it is correlated a lot of times with neovascularization. So we see a lot of patients who have pathology but no pain, right? But the one variable that tends to tease out when it comes to pain is neovascularization. So changes in blood vessel makeup within that tendon tissue, the matrix of vascularity kind of changes, and you end up having hypervascularity along with hypersensitivity. So think peripheral sensitization. This tissue now is trying to heal. You're getting increased blood flow in the area, but you're also getting a more sensitized tissue. You'll diagnose it with, really, it's going to be localized pain. Well, when we see patella tendinopathy, that pain should be just at the inferior pole of the patella. Palpable tenderness should be present, right? So you actually have decent metrics to rule in patella tendinopathy when you have that localized tender tissue. You just aren't going to be able to rule it out. And the reason you're not going to be able to really rule out patella tendinopathy in the absence of palpable tenderness like that is really because the correlation between symptoms and imaging or pathology oftentimes isn't quite there. We'll get into that a little bit more. It should make sense, though. It should be an extensor mechanism, right? Energy absorption type of pain pattern. So when they run, when they jump, right, it increases their symptoms. When they stop that activity, when they stop running and jumping, there should be a relatively quick decrease in symptoms. So it's connected to their activity that has something to do with the energy expenditure of the extensor mechanism. And then it should be dose dependent, right? So the further they squat, the deeper they squat, the more pain they get. The more load that goes on that patella tendon, the more pain they get. The more higher jump height, you're going to get more pain. So it should all make sense. It should all kind of correlate that clinical picture. You have to sort of differentiate it from patellofemoral pain. Patellofemoral pain should be more peripatellar in nature. So they're going to have pain higher up around the patella. The femoral condyles, the peripatellar palpation, might elicit their symptoms. The synovium might elicit their symptoms. It should be more diffuse in nature, and it shouldn't be. It's connected to the energy, absorption of the extensor mechanism, but not as closely related as like a patella tendinopathy, right? So the patient with patellofemoral pain syndrome, they're going to have pain with prolonged sitting. They're going to have pain well after the activity subsides, and it might take them a little longer for the pain to ramp up when they're performing the activity. And then ruling in and out, office fat pad most of the time is not going to be, a very common condition you'll see, but you do get irritation in that sensitive fat pad structure that's behind the patella tendon. So you just want to kind of make sure it's not that too, right? That should hurt, though, with some degree with passive extension. So you do get compression of that fat pad when you passively extend the knee, and then obviously that tenderness is going to be more lateral to that patella tendon, kind of off that center line. And then anterior meniscus is a completely different animal, right? They're going to have clicking, popping, pain with passive extension, and you've got a number of tests that you can do to try to incriminate that meniscus, Thessaly, McMurray, palpation. All right, some of the key principles we're going to look at here. So, first of all, just like most of the injuries we see, there are a large number of people who have soft tissue injuries, tendinopathies, and partial tears and swelling inside the tendon tissue, have no pain whatsoever, right? So there's a large portion of asymptomatic people that still have pathology, so it doesn't necessarily, the correlation isn't always there. We're going to want to integrate this pain monitoring model, and so that's been kind of popularized by Karen Silvernagel and the group out of Delaware. They advocate that you use this kind of 24-hour symptom window, right? If they come in at a 3 out of 10 pain, we perform exercises that increase their symptoms a little bit, but within 24 hours, the symptoms go back to baseline, back to that 3 out of 10, then you're okay, right? Where you're flaring people up and you probably need to scale your program back a little bit is if those symptoms are persisting beyond 24 hours. I use fairly arbitrary, but I'll typically ask the patient as they're performing the activities what their pain level is, and if it goes up above like 2 points usually on the pain rating scale, then I'll typically dial it back a little bit, not push them into pain. We've learned that it's not helpful to push these patients into pain and to keep eliciting symptoms as they're doing the exercises, right? So that pain monitoring model is important. And the last thing is just this pain kind of pathology paradox where you'll get a relatively quick, across the board, up to about an 80% reduction in pain over the first 3 months of the program, but pathology will still be present. So when we look at long-term structural changes, we want to load that tissue to create healing, to strengthen that tissue. That's actually going to take about up to 6 months. So in a lot of cases, we're not seeing the patient for that long. You got to make sure that they're being handed off either to a strength coach or some other program or some other wellness-related program or gym program or home program that's going to keep loading that tissue in a healthy way so that you can really take it out to the full benefit of the exercise, which is structural changes, tissue resiliency, and strength. Also considering kind of the holistic aspect of it and the central mechanisms, you know, this does look a lot like some of the other diseases that we see, and so tendinopathy, you know, tends to be present in those that have a higher BMI. It's not just because of the weight and the loading, it's sort of the systemic, you know, just health issue that they have, diabetes or genetic issues, and then of course, you certainly are going to consider the presence of medications. Statins, cholesterol-lowering medications, as well as antibiotics are both risk factors for tendon-related pain. We have a decent amount of literature that shows that if you take a course of antibiotics, a recent course of antibiotics, that you'll end up having spontaneous tendon ruptures, that occurs in a percentage of people, and then spontaneous tendinopathy or tendon-related pain that occurs in a number of people. So you do want to you know, just make sure, check there. You do want to just check and make sure to check their, you know, medication list and just see if there's a correlation there between the, you know, statins, antibiotics, and the recent onset of tendinopathy. All right, what I want to focus, is that more common with certain classes of antibiotics or all antibiotics? I'm not really sure, honestly, Amy. I have to look into that a little bit further. I think that, yeah, I really don't know. Cipro, right? Cipro, which is probably the commercial name, not the generic name, but Cipro is the one that you'll see a lot of literature on. I'm not really sure if there are certain ones that make you at more risk or have more prevalence of tendinopathy-related pain or not. Yeah, Cipro, C-I-P-R-O, you got it. Morgan probably does. Chime in there, Morgan, if you have the
I don't actually know which classes, but there's been a ton of research on Cipro. Like, there's a new study every year that comes out that's like, hey guys, if you're on Cipro, within 1 to 2 weeks, you have something crazy like 50% increase of a tendon rupture or tendinopathy developing. I think that they usually target Cipro because it's such a big antibiotic that's broad spectrum. But beyond that, I'm not sure of the exact class stuff that goes with it.
Good call, yeah. And I think it's like a listed side effect. There's a antibiotic or tendon-related pain is a listed side effect for that 50% increase. That's great. All right, I want to focus on pathomechanics now, kind of shift gears a little bit to sort of the stuff that we are going to commonly look at. All right, so extensor mechanism, right? Patella tendinopathy. And is an energy attenuation condition, right? And so when you look at loading forces, ground reaction forces, whether it's jumping, landing, running, whatever, you have distribution of force throughout the entire kinetic chain, right? And so you would expect, you would hope, you're going to have a relatively even distribution to some degree. You're not going to have one area of the chain dysfunctional, right? It's going to create more stress on another area. So a good example would be like if you look at on the left, I have a ground reaction force that's vertical. I also have a posterior ground reaction force when I jump forward. So if I jump forward and land, there's a posterior moment, and then there's kind of a superior moment as well. If my hip, right, if I'm not moving through my hip, I'm not controlling my hip, I don't have a nice soft hip landing strategy, obviously it's going to create more stress, you know, through the anterior knee complex. Same thing at the ankle, right? If I don't have that solid kind of cushion in the ankle dorsiflexion, then certainly that's going to create more stress to the anterior knee complex as well. So this could be causal in a lot of ways. This could be a causative factor, right, when you look at anterior knee pain or patella tendinopathy specifically. But it also, in a lot of cases, can be, you know, a stiff landing strategy as the result. And we've seen that, like some of these prospective studies where people with tendinopathy will land with a stiffer leg strategy, stiffer limb strategy, and you know, obviously not want to absorb forces through the knee as much, maybe as a protective response to the pain. So we typically look at them in a sagittal plane, right? It's going to have them squat. It could be bilateral, it could be single lateral. But I want to look at their sagittal plane movement. I want to look at their control. What's their ankle control? What's their ankle dorsiflexion looking like? What's their knee flexion looking like? Hip flexion, hip control, spine angle, right? I want to kind of get an understanding of their sagittal plane control. Some specific, break that down. basically, right, specifically. So what's that kind of hip control? If I look at the hip hinge, are they able to really have a nice disassociation movement of the hip from the knee? Right, I let them keep a soft knee, but can they flex that hip forward in kind of a deadlift type movement? You can use the dowel rod on the backs like that. It's kind of nice checking spine alignment. But I just want to see, does he have good hip control? Is he able to move his hip like that? And then Peter Malliaris, he looked at a group of volleyball players over the course of the season and tried to figure out like what were the factors that correlated to the ones that, what were the physical factors that correlated to the ones that ended up having a patella tendinopathy by the end of the season. And ankle dorsiflexion mobility teased out at the top of the list. And so that can be a valuable thing to look at in these patients as well. Show you like the little inclinometer test. So basically what you're going to do is have them lunge forward, keeping the heel on the ground. I want to see how far can you lunge forward with your heel on the ground. And I'm just measuring that with my inclinometer, that tibia inclination angle like that, right? So that's a closed kinetic chain dorsiflexion test. And if you notice a significant asymmetry side to side, you know, maybe, and that's on the same limb that has symptoms in the anterior knee complex, that maybe that's a risk factor or a causative factor. Now, my challenge with this is sometimes people are just bilaterally limited, and so I won't see an asymmetry, but it still might be a problem that you kind of want to address. So, you know, the normative values for closed kinetic chain dorsiflexion are not well established. I would say typically you see these around 35 degrees, right? In the healthy ankle, it's about a 35-degree inclination angle as they move forward. And that's in, you know, relatively young people that I'm seeing it. And then plantar flexion control or plantar flexion strength, plantar flexion power is going to be another very important thing to look at, right? Because a lot of times this is a posterior chain dysfunction. They just don't load their posterior chain, or stress going through the anterior knee complex contribute to the problem. So you can look at heel rise, you can look at a unilateral and try to compare side to side. Number of heel rise repetitions performed is a nice little test that you can do. Got a water ball there just to look like reference height, right? I want to see the same height every time. Once she starts to drop height and that heel is unable to rise to that full range of motion, then that's what you call the test and basically record the number of repetitions performed there. Starting at bilateral and then doing a unilateral comparison. Right, so that's sagittal, kind of those sagittal plane considerations. And then looking at the frontal and transverse plane, a typical step-down test, right? Think of shearing forces going through that patella tendon. If I've got hip weakness on one side, I lack hip control on one side, I'm going to see the valgus, I'm going to see the femoral adduction into rotation, which is really going to create kind of a shearing force through that patella tendon that also could contribute to the problem, right? So do your sagittal plane assessment, look at hip hinge, look at plantar flexion, look at dorsiflexion mobility, and then do your frontal plane assessment and kind of look, does her hip drop on one side? Does she have good pelvis control? Does her femur adduct and internally rotate? You know, what's happening at her tibia, knee position, all of that. And then quadriceps strength, which we know, right, arthrogenic inhibition, we know quadriceps going to shut down in almost any case of knee pain. And that may not be a risk factor or a causative factor. It may be a result of the knee pain. It's going to be probably hard for you to tell in most cases. Bottom line is I'm going to rehab the quadriceps, right? The thing is, I'm going to introduce load, right, and try to stimulate healing through the knee complex, and at the same exact time, you know, it's going to very much be a quadriceps strengthening program as well. So you're going to get in both those. Yeah, it's chicken or egg. I kind of always am like wondering, you know, is this the cause, the result? And then, but a lot of times it doesn't matter, right? It doesn't matter. So kinetic chain interventions, go back to the hip lecture. I think if you haven't listened to that one yet, that I did back in the early fall, we went through a whole number of exercise progressions for the hip. So if you're seeing the patient with patella or any knee tendinopathy and you think hip control is part of the issue, you know, I think that working them through that entire program of, you know, lateral stepping and clamps and side bridges and just all those kind of glute med, hip external rotator, and hip extensor progressions. And then looking distally as well, right? So we talked about plantar flexion strengthening, a very important as a shock attenuator, right? When you land, you want a good plantar flexor eccentric control, good explosive power through the plantar flexors, making sure that kinetic chain control is all there. Then for the frontal plane, right, if I've got somebody and I'm noticing big time tibial internal rotation, femoral internal rotation, you can also kind of look distally in the medial side of that foot ankle complex. They have good posterior tip control. This is short foot, which is a nice exercise to kind of build up the medial arch and strengthen the medial side of the foot intrinsics. What you're doing pretty much is just going to have to press the big toe into the ground. You're going to get a strong FHL contraction, obviously, but you're also going to get flexor hallucis brevis kind of controlling and firing there. You're also going to get the intrinsics of the foot firing as well. So it's a nice sort of medial control if you're getting that person that's deviating internally with their tibia, and then couple it with your hip strategy movements and your hip exercises. So, I mean, I could couple it with a squat, but I also, just to start, I won't want to like load that patella tendon in initial phase. I'll just do it with like a single leg deadlift like that. So he's creating short foot while at the same time extending his hip and working that hip hinge movement. How are you cueing that? Short foot, tactile. So sometimes I'll slide my finger underneath the big toe. Say press into my finger, or press your big toe into the ground without curling the toes, right? That would be more extrinsic. I mean, obviously get a lot of extrinsic contraction anyway, but I don't want them to compensate too much with it. So I don't want them to curl the toes. Put your hand flat on top of all the toes and just say press, press your toes into the ground, press your big toe into the ground, and then maybe tap that medial arch just to get them to kind of fire on the inside there. And the last point I'll make about kind of just exercise principles in general are that strength training alone will oftentimes not create the movement changes that you're trying to gain. So, there's a number of studies that have looked at putting people through hip strengthening programs, but not actually changing, right, the movement pattern, the landing strategy, in this case, the side cutting maneuver. So you have to integrate. We'll talk about this a lot of these kind of energy attenuation type of exercises, explosive exercises, deceleration, acceleration, cutting maneuvers. But I just want to make that point that strengthening alone is not going to get the job done. You need to integrate movement retraining as well. So breaking the program down overall, right, I've got pathomechanics, what I might believe to be contributing factors to the movement disorder, to the tissue sort of disease state, and then loading from a tissue healing perspective. And that's really where mechanotransduction, comes into play. So this is definitely an epic article. Really, Krim Khan, one of the great advocates of our profession. From the medical side, he's a physician, but strong advocate of what we do as physical therapists, and really one of the leading tendinopathy researchers. And so what we do, from an exercise loading perspective, is really front and center in the literature to create healing, to create tissue resilience, to create strength that's needed to help these patients recover. And that's really what mechanotransduction is all about. It's all about stimulating, right, at a cellular level, stimulating that tissue to become stronger, to lay down more tissue, from a collagen healing standpoint, and to become more resilient. So that's open access. Just Google mechanotransduction, Krim Khan, or mechanotherapy, and you'll see it. So the progression is going to a lot of times be kind of your standard isometric, light isotonic, progressing them to heavier loads, then progressing to more dynamic, challenging movements, right? So I usually will gauge that based off of sort of irritability, baseline strength, underlying pathomechanics, all that sort of stuff. So let's say we've got kind of one of those sort of, not worst case scenarios, but relatively irritable case, right? Relatively high irritability, patients unable to tolerate a whole lot of load off the bat. We're definitely starting with isometrics and probably a ton of contralateral training, aerobic capacity training, kinetic chain work, right? All that other stuff. The nice thing about the straight leg raise is I can get a strong volitional quadriceps contraction. So it's a great basic exercise, as you all know, but I'm not getting a whole lot of specific tensile force going through that patella tendon because the knee's in that nice extended locked out position. So the patella tendon is not going to get as irritated. I'm also not going to kind of mess with the knee joint here in the locked out position. You're going to want to also, and I think a nice concurrent one is just isometric loading at varying knee angles. Because the downside of this is I'm really training them in the position that they don't have a problem with, right? People with patella tendinopathy don't have an issue at full knee extension, obviously. Their issue is going to be at deeper angles of knee flexion. So isometrically, I mean, he's doing this isotonically here, holding the extended position, lifting that leg off. That's a challenging move. But I want him to hold varying angles of knee flexion. Start closer to extension, and then just move down 10 degrees for all your holds. I would like to see where does he have pain, right? Where does he have pain? And can I get him to do isometric holds right above that pain angle? So let's say he's got pain. As soon as he drops down to about 60 degrees of knee flexion, the onset of symptoms come on, the patella tendon. I'll bump him up to about 50 degrees, right? 50 degrees closer to knee extension, and then have him do iso holds there. It's typically a 45-second hold in the literature. These are 45-second hold isometrics. I still think that's pretty arbitrary. You know, I'm looking at their tolerance, their fatigue level to kind of decide dosing parameters, but it's just good to know 45 seconds is sort of the average kind of standard that you'll see. And leg pressing angle. So this is kind of nice as well. So I'm going to get more loading with an isometric leg press and then a whole different positions. I can add perturbations like that, right? So we can add that if we thought that there were transverse and frontal plane issues, we can add, perturbations to kind of push them into adduction and abduction and internal rotation. But leg press at varying angles like that is a nice one. And then I think actually a more challenging one, the isometric, is just a standard wall sit. You don't see this in the literature a whole lot, but a wall sit is a very taxing quadriceps exercise. You get a lot of loading through that patella tendon, but you can do it, you can control the range, which is why I really like it, right? So those patients, I'll just try to get an understanding of squat depth, where does the pain come on, at what point does the pain come on, and have them do wall sits right above that point, right? So I'm going to slowly chip away at that knee flexion angle and slowly get deeper and deeper and deeper into that knee flexion angle with a wall split. That's like a hallmark kind of patella tendinopathy anterior knee pain exercise for me if they can tolerate it once we get to that point. This is a great little outcome measure. I can take that inclinometer and I can have them do I can do a regular squat, a bilateral squat. I can do a single leg squat. I'm going to have him go into the deepest knee flexion angle he can with the inclinometer sitting on the distal anterior aspect of the femur. And the further he goes, I want him to go down as far as he can. I'm just going to say stop at the first onset of symptoms, right? So as soon as your symptoms are reproduced, I want you to stop, and I'll measure that angle, and I'll record that, right? So it's a really nice objective way to get the thing about range of motion, right, with tendinopathy cases is it's pain under loading. So you measure their knee flexion, it's fine, open chain, it's no problem. As soon as you load them in a single leg squat like that, you'll get a nice reproduction of symptoms and figure out the angle. So it's a nice little technique with the incredibly useful inclinometer that we use it for everything. All right, squat progression. So, I think it's going to be like, what is this person? You take pain level into it. I think that's another way to do it. So, like with that depth thing, right? It could be that they just have a baseline pain just standing there of 5 out of 10. I still want, and so maybe what I say is like, what's your worst pain, or what pain do you, at what point in the range does that pain increase, and I'll record that range. I think you can kind of have like a by comparison or a couple comparison where you look at range and intensity and correlate the two. I guess for me it just gets a little confusing, right? I'm like looking at two different variables at the same time, and I just honestly just haven't tried it. But I think it's a good. I don't see anything wrong with it. If you can kind of match pain intensity or track pain intensity throughout the range, I'm sure in some cases that's variable or important. With the squat progressions, it's like, is this somebody that's already squatting? Like, that's my first question, right? Are they already squatting? Are they already proficient with the squat? And I'm squatting and progressing the squatting from a low tolerance standpoint? Or am I teaching them squats because I want to start loading their quadriceps and their knee extensor mechanism, and I really need to clean up or instruct their squat forward a lot in the beginning, right? Those are kind of two separate scenarios. So if I'm looking at squatting and I'm just looking at overall trying to teach them to squat, trying to get them proficient to squat, this is going to be a more involved process. And so air squat would be where I'd hang out for a while, and I'll probably jump ahead to what I'm going to cover in the next few slides. But just as a basic progression from the air squat, I can start integrating. Goblet squats will be an easy one in the clinic that doesn't have a nice barbell rack setup, a squat rack setup. So kettlebell under the chin, right? Just a kind of load a little bit with the squat. I can do it with a dumbbell if I want. I can increase load to the extensor mechanism by controlling for this tibia inclination angle. So the Spanish squat is basically tibia up against the ball, up against pushing back to the wall, and then he's going to sit back. And so you can see that leverage that's going to occur through the quadriceps and the extensor mechanism, right? So that's a nice one. Belt would be kind of the alternative to, is basically he's got something in front of him, right? Something very sturdy structure. Any type of belt, gait belt, thick band around the back of his knees, around the structure, and he's going to sit back. And all that does is really control inclination angle. So it's like a hack squat. Talk about this here. It's like a hack squat that I'm keeping that tibia inclination angle upright. So for the person that's not squatting to begin with, this is a 55-year-old runner that comes in with Patella tendinopathy. They don't have a strong history of strength training. They haven't been doing a lot of cross training, and I want to try to get them on sort of a loading program. I think a great place to start is when you're holding something in front of you, where you're able to stabilize your trunk with your hands in front of you. It automatically kind of allows a nice hip flexion, sit back movement. It controls that tibia inclination angle. It controls that spine inclination angle, right? She's not gonna fold forward as much. She's able to kind of maintain a little bit more of an upright trunk. So that's a nice little kind of crutch, right, to initially teach it that can help. And then a nice one that's a little harder would be sort of a standing in front of the wall squat movement, right? So now what I'm doing is putting a wall in front of him. He can't bring his knees forward too far, right? The people that don't want to use their hips are either going to fold in the trunk or they're going to drive the tibia forward, right? The tibia inclination angle is going to increase. Their knees are going to come forward. The wall blocks them from doing that, obviously keeps them from doing that. Same thing with the trunk inclination angle, right? You see those people that fold forward, right? They fold their trunk forward every time they squat. He can't do that with the wall in front of him. So it kind of forces that upright chest, forces that extended spine position, forces him to put his weight back through his heels. Some people you might, put weights, or just a little 10-pound plate underneath each heel to get him to load through his heels a little better, 2x4 under his heels to get him load through his heels a little better. Start him kind of further away from the wall, right? And as he progresses, inch him closer and closer. So I want to see that nice hip-knee control, good squat form before we dive into the loading program any further. What we used to always see people do is put them on slant boards. And so the slant board essentially takes the posterior chain out of the mix, kind of increases load to the extensor mechanism, puts more load through the patella tendon by taking that posterior chain out of it. So the gastrocs are insufficient, the hamstrings are going to be more insufficient, the glutes going to be more insufficient, and he's going to be required to use more quad work through that. It's a nice one if you ever want to just get a good quad burn or just like work your quads. I mean, it's essentially what they used to do is a sissy squat, right, where the knees are coming forward dramatically, and that's just forcing the quad to work harder. This is kind of the old sort of Alfredson protocol for slant board that we don't really advocate for too much nowadays. HSR is all the craze nowadays. So heavy, slow resistance is what the patella tendon seems to respond a little bit better to. So these are, and this is the protocol that was first published by that conscript guard group. I don't know that this is the only way you have to do it or anything like that, but this is just the way this has been published. So it's a regular squat, a back squat is how they describe it, a leg press and then a hack squat. Most rarely does somebody have a hack squat in the clinic, so I'll show you some different ways you can kind of reproduce that or emulate that. But it's 3 times a week program. They're not going below 90, so like, you know, there's the whole, I saw Mitch's video the other day on squatting below 90, and, you know, I agree with most of what he's saying. That's the healthy knee, right? In the healthy knee, you're probably not going to create injury for most people squatting deep. It's actually probably protective and healthy, and I think he made some good points. But the person with patella tendinopathy, it's a bit of a different case, right? The further they elongate that tissue, the further they stretch that patella tendon, the more kind of, you know, irritation they can get or reproduction symptoms they can get. So I think that's probably the premise behind that blocking these people at 90 degrees of knee flexion, but it's a slow key variable, 3-second down, 3-second up repetition every single time, right? So it's heavy. They're going to progress them up to about a 6 rep max eventually, but it's a slow rep, and you can see the progression there. So I think the challenge that we all have is, and by the way, the population here is not like a heavy Olympic lifting population. I mean, this is general population, patella tendinopathy, athlete, non-athlete. So this is generalizable to a lot of our patient populations. The challenge is just what's their baseline strength and what equipment do I have in my practice, right, that I can actually pull this off. So I think that you got a couple options, right? You don't have tons of weight, so you're not going to be able to, in a lot of our cases, do a ton of bilateral work. Single leg loading, though, I can get people to a 10 rep max, 8 rep max, 6 rep max, single leg loading, especially if they're going to hold, you know, kettlebells or dumbbells or weights in their hands. So that's a nice kind of way to load them up at a little bit of a higher level of intensity, you know, and try to stimulate healing through that patella tendon. So that would be the leg back, kind of legs on the chair, assisting her in that squat. Probably wouldn't do that for the person with maybe a history of like SI joint pain, right, where you maybe tweaking that SI joint and kind of split squat stance a little bit. This would be the other alternative. So you've got holding on to, you know, some type of a structure and then squatting with that single leg with the other leg forward. It's going to be hard to load that one, but I kind of like it from a spine inclination angle to teach the single leg squat. That might be a nice one to start with. Warming them up in that regard. All right, and then the last phase, right? So it's correct pathomechanics, address tissue loading, you know, from a standard tissue loading progression, and then it's going to be energy storage exercises. So I have to integrate deceleration tasks, acceleration tasks. That forward jump like that would be a great example, right? A simple bilateral forward jump, which is having to accelerate and explode and use her posterior chain power, use her extensor mechanism power, but then the landing, the slowing down, that hip knee coordinated movement can be very healthy to kind of restore that lower limb functional pattern. Cutting tasks, split squat jumps, plyometrics, box jumps. Sky's the limit. You know, there's so many different things you can do, I think, unique to that person's activity and what they're getting back to do. I'm going to dive into some of these other tendons now. Before we do that, any questions, any comments just on anterior knee tendinopathy mechanisms? I didn't touch on the quad because you just don't see quad tendinopathies with the same prevalence. The principles are very similar in most ways. But any questions on that, tendon tears, anything like that? We can we can round up questions at the end as well if you don't have any right now. All right, so let's move on to the lateral knee. So lateral knee pain, and obviously IT band is something that we're going to get into here, and then biceps femoris coming down, the lateral aspect attaching the fibula there. And then we're going to get into the popliteus a little bit here, the role of the popliteus. Real quick, I'll just say this. Even in, so like I have some popliteus specific exercises, Jamie, and I mentioned posterior lateral quadrant injury and Popliteus, the role of Popliteus in the Facebook post. And so I wanted to include this, but it is very much the proprioceptive input, right, to knee movement. Popliteus is a major player in that. So these small muscles that have a high amount of GTOs, right, muscle spindles, that has a strong proprioceptive role. So even though you're not dealing with a specific Popliteus injury, doesn't mean that you're not going to want to integrate maybe a Popliteus specific exercise or something to try to kind of target rotational control of the tibia that we'll dive into here a little bit. So IT band related knee pain is tricky. We used to, I guess the old theory was always kind of like the IT band gets tight, it gets bound down, and friction rubs over the lateral femoral epicondyle, and you'll get inflammation in the distal IT band and all that. There's actually not really been any correlation demonstrated between the over test or IT band tightness, right, and IT band related symptoms. And actually the opposite's kind of been demonstrated to some degree. It sort of looks a lot like Patella femoral pain syndrome, patients presenting with weak hip abductors falling into intra-rotation adduction. If you see that in somebody with lateral knee pain, obviously you're going to hammer the hip and try to correct those pathomechanics. But you know, it could be that it's micro tearing. In this case, it's a cyst. It could be that it's a cyst. It could be that it's friction and irritation on the undersurface of the IT band. That fascia is, you know, it does have nervous system, nervous tissue in it. So like it could be a sensitized, you know, aspect of that kind of interface between the IT band and the osseous structures underneath of it. But most of the time you see now just call it lateral knee pain. And I think you got it inserted between IT band and biceps femoris tendinopathy, which I think in a lot of ways is going to be managed a little bit differently. Biceps femoris is tricky because see how tendinous it is on the right image there? It's fairly tendinous, even kind of high up, right? Where you would think it's become muscle belly. The long head particulate comes down attached to the head of the fibula, but it's going to be tendinous a little bit high, kind of almost in that region of the IT band, but more posterior. You see tearing here of the biceps femoris on the left MRI. And so, you know, we'll use the same principles for these tendon injuries and looking at pathomechanics, but then we're going to slowly load that biceps femoris and look at all of its functions and the role it plays. Just quick little reminder. So the short head, right, attaches mid shaft of the femur and then into the distal third of the femur. The long head of biceps femoris attaches up on the pelvis. So hip extension, the correlation between hip extension and their symptoms, or you know, if I elongate it by extending the knee and flexing the hip like a kind of straight leg raise test or hamstring type of a stretch, right? That elicits I want to know if that elicits their symptoms because that kind of helps you prescribe exercises. Is the long head involved? You need to address hip motion as well. Popliteus injuries do occur, very low prevalence there, but you're going to see pain right under the LCL. Hard to discern LCL, right, tenderness from Popliteus tenderness because the tendon location is kind of right in that same spot. Obviously, you're going to Barrett's test the LCL, and Popliteus shouldn't have pain with that. There you see a Popliteus mid-substance or mid-muscle belly strain, right, Popliteus muscle strain, and getting swelling in that Popliteus muscle there, which we do see to some degree with people that tear their ACL. People tear their ACL because of the rotational force going through the knee, they'll kind of strain that Popliteus or even tear it. So then on the medial side, it's all about the pes anserine, right? Pes anserine and semimembranosus on the medial side. And so that can be both a bursitis, right, where we get sort of swelling and inflammation between the tibia and the pes anserine on the medial side. It can also be a straight pes anserine tear. Any one of those tendons can get partial tear, swelling within it, tendon disorder, tendon breakdown within it. And so we'll kind of load a loading program for that now. All right, so I want to discern, right, is it strictly a knee flexion issue? Is it a knee flexion hip extension combined issue? So depending on which one is involved, if I elicit symptoms with the active hip extension coupled with knee flexion, right, that's going to, in my mind, put them into kind of that hip loading category concurrent with the knee exercises. So that's a nice little movement that I can have him do there. He's flexing the knee, extending the hip with a couple movement. The other thing is the association with the plantar flexors. And sometimes these proximal gastroc strains can kind of mimic it as well. So he can put his fingers right on that proximal gastroc attachment site and have him, as he's flexing the knee, right, contracting those hamstrings, resist the ankle plantar flexors at the same time. So those couple movements, I think they can be diagnostic in nature, and sometimes they can help you rule things out, but they can also help with just general, you know, getting the system ramped up, getting the motor pattern going, starting to load that lower limb and all those tissues. And then coupling rotational movements with it, right? So anything on the medial side, including popliteus, but anything where the muscle belly is on the medial side, so semimembranosus, semitendinosus, popliteus are all going to be internal rotators of the tibia, right? And so what you can do, I'm doing my right hand here, is I'm actually trying to pull her into external rotation, trying to get her to really recruit that medial side, start loading, you know, in this case, semimembranosus, semitendinosus on the inside, right? So as I'm going to eccentrically pull her down to extension, she's going to concentrically pull that knee into flexion, and I'm going to work that coupled rotation with the movement, trying to pull her out into external rotation at the same time. Tactile cueing, verbal cueing. Same deal for biceps femoris on the other side. Biceps femoris, right, that should externally rotate the tibia. You're getting a much better load from biceps femoris if you try to pull her into internal rotation of the tibia, right, and resist that external rotation movement of the tibia as she flexes the knee there. I can couple hip angles with it. I really like, from a symptom modification standpoint, to couple hip angles, right? So if she can't tolerate this, I'm starting to try to load that knee flexion angle and she can't tolerate it, try changing the hip rotation angle. Sometimes you put that hip in a little bit of a different position, internally rotate the hip, and then load it again and see if they can tolerate that. You can also sometimes get elicit like a little bit of a stronger contraction by changing that hip rotation angle at the same time. Popliteus primarily active between 20 and 60 degrees of knee flexion. We think that that is a big time proprioceptor for that eccentric lowering, right, and that last kind of bit of knee extension movement down to about 20 degrees. So you can kind of try to isolate sort of 20 to 60, tap the popliteus, get her to fire, get her to internally rotate the tibia at the same time, sort of controlling, right, controlling that knee flexion movement like that. You can also isolate tibia internal rotation. You're going to best achieve this at 90 degrees of knee flexion. So popliteus activation is actually greatest at 90 degrees of knee flexion, even though one of its prime roles is initiating knee flexion and kind of unlocking the screw mechanism of the knee. If you flex the knee to 90, have her point the toe across, you're going to get a lot of posterior tib activation here as she's inverting the foot ankle complex, but you're also going to recruit popliteus, semimembranosus, semitendinosus as she kind of internally rotates the tibia there with the band resistance. So nice low level isotonic kind of work for that sort of posterior tendinopathy. And then integrated weight-bearing control. So can they actively internally rotate their tibia or externally rotate their tibia in a weight-bearing environment? So I can initially, people for like to have like a crutch, right? I can have them try to use the hip to kind of initiate it. That's pretty easy. I can say just move your thigh inward, move your thigh outward, right? I'm getting that internal and external rotation in that regard. But eventually, I like that to be initiated with either the medial rotator of the tibia or the lateral rotator of the tibia, depending on which one I'm treating, right? Get that to initiate kind of that rotation of the tibia, sort of get that triplane movement. And dynamic kinetic chain movements where I'm coupling movements, right? In this case, knee flexion with internal rotation of the tibia, right? And I can even kind of get a little bit of hip external rotation coupled with it at the same time. So the medial rotators of the tibia, this is a great popliteus exercise, great semimembranosus, semitendinosus exercise. Flex the knee, internally rotate the tibia, externally rotate the hip. You can add a little bit of hip extension into that to really accentuate that hamstring with that movement like that. With nice loading. Standing upright, weight bearing, open pain, wobbling. Then there's a couple of kind of neat things that you'll see in the literature. So an eccentric treadmill exercise is you're going to try to load the hamstrings by having them stand backwards on a treadmill. So they're facing the back of the treadmill. They're holding on to the handrails, obviously. Their non-involved leg is standing off to the side on the platform of the treadmill, not on the belt. The involved leg is you're going to put the treadmill at about a half a mile an hour, real slow to begin with. And so the treadmill's moving, right? And the involved leg, they're going to extend the hip. They're going to plant the ball of the foot on the treadmill, and they're going to try to fight that treadmill from pushing their leg forward, right? So they're going to eccentrically load the hamstrings by sort of resisting that treadmill moving back like that. Then you can just up the speed to up the dose. I like to you can try to get them to sort of isometrically hold it for a little while at the slow speed, and then bump the speed up a little bit to 1, maybe 1.5 if somebody's really strong, and force them to kind of slow that belt down and eccentrically load it as they go through. Cushman described this as more for like a proximal hamstring tendinopathy, right? Because you're dealing with that kind of two-joint component in the proximal hamstring tendinopathy, but certainly a nice loading strategy for a lot of different hamstring injuries. Then coupling knee and hip movement. So this will be a nice sort of challenging alteration to the bridge, where he's going to bridge up, flexing the knees, and he's going to slowly extend and eccentrically extend the knees and extend the hips, right? So that can be kind of a challenging hamstring exercise, especially if you progress that to one leg. And then coupling dynamic kind of lunging movements at the same time. So we really emphasize a lot of those tibial rotations, and you can do that just by altering trunk position, right? So if I have you lunge forward and then have you rotate your trunk, I can kind of force an eccentric control, right, of that tibial rotation in a weight-bearing environment, which can be kind of nice as well. And then stepping tasks with rotation. So now I can have you actively toe out, right? Toe out so that tibia is going to rotate outward. Have you do active toe in. But I want to prepare them, right, for that control motion, that eccentric motion of control through the rotation of the tibia while that hamstring's having to control them eccentrically as they step forward like that. Really thinking about hip now, even in the single joint, so short head of biceps femoris strain, short head of biceps femoris tendinopathy, you will still light them up, right, with a hip flexion movement like that, just because of position of the knee and bringing the body weight, bringing the trunk forward like that. So this doesn't have to just be for the two-joint tendon injuries and muscle injuries. You're going to integrate deadlifts, right? It's one of the most protective posterior chain exercises that we can probably integrate. So I think if I have anybody with any type of posterior chain muscle or soft tissue tendon disorder, I'm certainly at some point going to start loading them, with a nice hip hinge deadlift like that with a kettlebell in this case. But obviously you can, based on your setup and your equipment, use a variety of options. And then single leg. Now I'm not only getting kind of the benefits of the posterior chain loading, but I'm getting it in an environment where I'm having to work balance. He's got to control his head position, trunk position, disassociate, hip disassociation with that movement. So another one that is very protective, right, for those soft tissues. And then changing angles with that too. So if I'm specifically trying to target, in this case, like let's say I want to target her medial side, right? Maybe she's got a semimembranosus strain or a semimembranosus tendinopathy, a Pezzi-Serine issue. Have her reach outward across her body, right, out to the right in this case, lateral, and she's going to eccentrically lower that inside muscle quite nicely. If I want to stretch biceps femoris, maybe I have her go the opposite way. If we ever go more medial, go towards the inside, reach with that right arm and go towards the inside there to load that up. Typically start away from the symptom reproduction, right? So if she's got a biceps femoris strain, probably not going to reach out away first. Probably going to go toward the side of the muscle, but I'm loading. I'm going to get a nice concentric phase, right, as she comes up. And you might just control height and depth of that hip hinge. There's a lot of different things you can control if she's getting symptoms. You got to kind of scale it back a little bit. You can roll a ball to them, so this is kind of nice because maybe they're unable to really necessarily control the direction they're going to move in, or they're unable to decide the direction they're going to move in the beginning. You roll the ball specifically to different positions, have them hip hinge, control that hamstring. Posterior chain loading. All right. So the one thing that I didn't dive into as deep was kind of the difference between tendinopathy and muscle strain or muscle contusion. The rehab for those in a lot of ways is very much the same. The primary difference being muscle tissue is so vascularized, it's going to heal a lot faster. And I don't have to necessarily be as aggressive with the loading program. So with the muscle strain, right, I'm going to let things heal, I'm going to let things progress, and I'm probably not going to load them up as heavy because I don't need to stimulate a healing response. I don't need to stimulate irritability in that tissue to try to get things ramped up to start healing. It's already occurring, right? So with the muscle strain and the muscle contusion, I'm more kind of worried about maybe excessive fibroblast laydown, and maybe scar tissue. So I might do more lengthening work, more soft tissue work, and then kind of a slow loading progression. But the exercises are still going to be, the same. I don't know that there's a whole lot of difference between exercises when you're trying to load tendon tissue versus muscle tissue. So that is soft tissue injuries around the knee. I'll open up for questions now. Specific things you want me to go back and touch on again, anything you want me to show again. Happy to do that now. And you can use chat box if your mic isn't able to come through.
I got one for you, Eric. What do you think the most common knee injury is that you see, and why do you think that it's so prevalent?
I mean, my practice is like, so I'm teaching most of the time, right? I saw 2 patients today, just to compare to everybody else. And that was actually a busy day clinically. So I'm not a good, slant. But for those 2 people, I did take about a solid 2 hours to see both. So maybe I'm not a good barometer probably, but when we look at epidemiological literature, anterior knee pain is the most prevalent in the younger population, obviously DJD and osteoarthritis in the older population. We're going to dive into that a lot next time. But yeah, I mean, gosh, it's got to be your region, the people that are in your community, the activities that they're performing, their health profile, the work environment in that area. There's got to be so many factors I can't imagine. But I would imagine your practice and your kind of in the Pacific Northwest and what you're seeing is probably, to some degree different from what I might see, south in Northeast Florida. What are you? I'll fire it back at you, Morgan. What are you seeing a bunch of?
I would say I see a ton of lateral knee pain and patellar tendon region pain. Not necessarily tendonitis, tendinosis. Some patellofemoral stuff. I also treat a lot of cyclists and runners, and so that plays into a ton in terms of weakness patterns and like their bike setup and how they're running and all that kind of jazz. So I see a slightly different population. But I don't know if the Pacific Northwest has different knee pain because we're like all fairies hopping through the woods or why, but apparently we do. I will say in Haiti, we see a ton of knee OA, and a lot of it I would attribute to the fact that people are walking uphill and downhill to get everywhere because it's a mountainous region. And they're often carrying loads on their heads. So they're ending up kind of in a extended lumbar position with really, really tight anterior structures, but really, really great mobility of their hips and posterior chain stuff. So that's always been interesting to me, but there's a lot of patellar and knee OA stuff in Haiti for sure. So
yeah, the activity is interesting though, because I think in a lot of, I mean, what I'm starting to like see more of is in the literature, it's just like this idea that, you know, the sedentary individual is actually at much greater risk of knee OA than the individual who's active. But I mean, I think you got a lot of factors in Haiti that you know, maybe different, but yeah. Well, when you said lateral knee, like the first thing that popped, you know, is just cyclist, right? That's like one of the big cycling knee-related injuries. But
totally, seats too high, almost always. It's an easy one.
Anybody else? What tests do you use to determine muscle strain versus tendinopathy at the knee? You know, so this is the one issue with all this stuff. We don't have a great statistical metric, sensitivity and specificity for the physical exam, right, in any of these soft tissue injuries. Location would be everything to me. So, I mean, if I'm seeing like what seems to be in the muscle belly, then, you know, obviously that's going to kind of lean you more towards muscle strain, and then the onset too. The tendinopathies, like they'll oftentimes report an instance where the symptoms came on, you know, stuff like that, but it often is a gradual progression of pain over time, and they've had periods of exacerbation, periods of remission, periods of flare-ups, you know, related to activity, whereas the muscle strain is like I was running and I cut to the left and an immediate onset of, you know, mid-belly hamstring pain. You're like, all right, you know, of course it's going to be muscle strain. And I do think too, again, like it might, you know, say it doesn't matter, but I know I'm going to take them through this process of restoring the biomechanics, slow progressive loading through the joint or through the region. And, you know, if I'm wrong about muscle strain versus tendinopathy, it might not be the worst mistake, right? It might not be the end of the world. But I do think location. Tendinopathies should not typically present with any ecchymosis. Muscle strains quite commonly will present with ecchymosis. So if you're seeing bruising in the skin around the region of symptoms after an injury, you know, muscle strains like the first thing that's popping into your mind, right? Obviously, you ruled out the joint and other tissues like that. Thanks, Christy, for asking that.
Eric, what success have you had with trying to reverse kind of skeletal deformations like varus valgus in people who are probably going to end up being a knee replacement candidate? I know we see a lot of valgus, but I have a patient right now who has some really bad varus, who is after some rotator cuffs and stuff is pretty much done with surgery, not interested in a knee replacement.
Yeah, I mean, I got a bunch of stuff dedicated to that. When we get into the degenerated knee in our session 2, but have you tried an offloading brace?
I haven't. He wears like one of those Tommy Copper braces, and then I do a lot of seated TFJ distraction. Oh yeah, that looks nice. Have you had success with those?
Yeah. So like it's I mean, so I want to like figure out like where are they at in the progression. I'm going to show next time like a bunch of knee OA manual techniques, symptom modification techniques that you would use to try to kind of reduce a valgus or a varus or take stress off one of the sides just to see does it change the symptoms. That deformation is very much, you know, if you see it's true deformation, it's not a movement pattern, very much a structural thing. So anything that we are doing, and not a, and it isn't necessarily something that's always been there, but it's a progressive structural deterioration. And anything that we're doing is probably offloading, right, for the purpose of symptom reduction. And I don't think I'm going to change it, but it might not need to, right? It might be that you take away the stress just enough to kind of desensitize that knee, less peripheral sensitization, and then you're able to kind of put them on a progressive exercise program and they do well. But anyway, the offloading brace would be a nice kind of like, I guess not long term, but you know what I mean, longer term sort of fix. Let's on the pes screen a little more. Oh, Allie, yeah. You brushed off the pes screen. All right, so let me go back to pes serine a little bit more. So you've got three muscles, right? The semitendinosus is going to sit most posterior to the pes serine. If you take your fingers and kind of come down your medial knee joint and take three fingers and sort of just place them just on the inside of your knee, on the medial side like that, that's basically the three right there, right? So it's going to be semitendinosus right here, gracilis, and then sartorius most anterior, right? What will happen with those patients is either it's a pathomechanical thing where they're internally rotating and adducting, and you know you're just seeing funky kind of knee movements, and they're starting to beat up the tendons on the inside, or it's like a strain that's a little higher up, like so a true semitendinosus, semimembranosus strain that's a little higher up, and then you can also get that kind of bursitis sort of issue in there. So what I'll do is so you're going to examine contractile testing, right? Flex their knee, internally rotate their knee, and kind of manual muscle test, see if that elicits their symptoms. You're going to palpate kind of all along here and try to see if that elicits. Adduct them, have them actively adduct the hip and kind of see if that elicits their symptoms. And then for sartorius, it's going to be a knee extension, external rotation, kind of coupled movement sort of. And I don't know that is as prevalent as an injury that you might see as much as you would see the hamstring issue. So anyway, that is that. And then it really is just back to kind of the principles, right? I saw an adduction, internal rotation movement in the single leg squat. I noticed they were valgusing a whole lot, and those trunk coordination isn't that great. Then address that. Or I noticed maybe their hip hinge movement wasn't all that great. Their plantar flexion strength isn't all that great. Their dorsiflexion mobility isn't all that great. Then I'll address that. So trying to get at kind of the pathomechanics and then slow loading, just loading and progression. And what I showed is primarily semitendinosus, semimembranosus type of rehab. Obviously, you could take them through an adductor program. You could address, I'm sure you could get creative and load the sartorius in a number of different ways as well. But it's same principles, just knowing kind of that anatomy and mechanics of those local tissues there. No problem. What we will do is, again, real quick, I have really enjoy when you want to discuss your cases in the clinic. So I don't want anybody to ever think like they're bothering me or this is like a dumb question or anything like that. So DM me on Facebook, no problem at all. And then what I did for a few people last time was we set up phone calls and we just talked through, because a lot of times I can't get enough info from you on Facebook. And so if we just set up a phone call in the evening when you're done with your clinical work, we can talk through any case you want. So it doesn't need to be knee cases necessarily. If you want to jump back to the shoulder and the stuff that we covered a couple months ago, or bring up a shoulder case, an ankle case. I mean, my kind of thing is extremities in general. By no means am I a hand wrist expert, but if I can't answer a question or I don't really know how to help you, I can certainly get you resources or steer you in a direction. And sometimes it's just getting a different person's perspective that's kind of nice as well. So a lot of times you guys are on the exact right track, and I don't know, what I add other than just tell you you're on the right track and maybe throw a few other ideas out at you. So anyway, anytime you want to take advantage of that, feel free. And those of you that will be in Vegas this weekend, I'll see you then. Everybody else, I will see you in 2 weeks. We will dive into the kind of aging knee, degenerative knee, knee OA, and all those conditions that kind of go along with that. Yeah, Jacob, anytime, buddy. Don't hesitate. All right. See you guys.